Presenting about a 39-year-old female housewife who had come from West Bengal to the medicine on OPD with chief complaints of right-sided headache and right-sided facial pain, which progressed over a course of 6 months to the complaint of decreased sensation over the right-sided face altogether. She's been having bilateral ankle pain and swelling for the last 2 months. She was also noted to have a skin lesion over her leg, which had healed over the last 2 months. And for the last 15 days, she was having intermittent fevers. So the timeline of illness, 6 months ago, she had developed right-sided facial pain, but there was no decreased sensation or no other facial cranial nerve involvement. Slowly over progression of time, 3 months, she started having difficulty walking. And at 2 months, she had started developing painful sensations over the anterior tibia. And at the same time had started developing decreased sensation over the right side of the face. 4 months into the illness, 2 months before presentation, she had very obvious knee and ankle swelling, and 15 days prior to presentation, she had intermittent low-grade fevers. She had sought medical treatment prior to her presentation in CMC and was started on oral steroids and carbamazepine. On oral steroids, she felt symptomatically better. However, the pain persisted at a lower degree throughout. She had no other known comorbidity. She was not a known diabetic, hypertensive, and there was no history of any TB in the past. On examination, she was vitally stable. She was afebrile as well. She was pale and was noted to have fetal edema. She also was noted to have a left axillary subcentimetric node, and she had healed lesions over both her anterior aspect of her tibia. Systemic examination, CVS RS and perabdominal examination was normal. CNS examination showed decreased sensation over the facial upper limb and lower limb sensory impairment compared to the left. There was corneal reflex. Jaw jerk was absent. She had right ear bone conduction more than air conduction, and she was also noted to have bilateral ankle arthritis. So as for her preliminary investigations, her complete blood counts were elevated with a neutrophil predominance. Creatinine LFT was normal. Thyroid levels were normal. And she was also, PT-APTT was also within normal limits. Blood culture had no growth. For her further evaluation of the acute chronic progressive headache, an MRI was done, which showed plaque-like homogeneously enhancing dural thickening along the right tentorial reflex, extending into the Meckel's cave, and bilateral medial temporal lobe, right more than left. And mild diffuse pachymeningeal thickening was also seen. So I'd like to take this opportunity to discuss about pachymeningitis and the approach to a patient with pachymeningitis. It is a rare inflammatory disorder of the cranial and spinal dura, which results in focal neurological deficits. And diagnosis is mainly by magnetic resonance imaging, which shows the dural thickening and contrast enhancement. It can be diffuse or focal. As in this case, we saw both focal and diffuse findings. The differentials for pachymeningitis include infective, inflammatory, neoplastic, and other causes. Most commonly tuberculosis, syphilis in our setting. Inflammatory, first differential that we can think of is sarcoidosis, IgG for related diseases, and Wegener's granulomatosis with polyangiitis. Other inflammatory syndromes like rheumatoid arthritis, SLE, giant cell arthritis, Behçet syndrome are also known to be associated with pachymeningitis. Neoplasms such as lymphoma, carcinomatosis meningitis can also cause pachymeningitis. As for her diagnostic workup, as part of the initial evaluation, we had done an MRI brain with contrast. Further CSF analysis showed normal glucose proteins, and opening pressures were also normal. CSF culture showed no growth, and expert was also not detected. Cytospin was also negative for malignant cells. As far as the etiological evaluation, we had done a syphilis screen, which was also negative. Anti-SSA ELISA, anti-SSB ELISA was 0. CNP ANCAs were less than 2. ANA was negative. Complements were normal. IgG IgA, and IgM were also within normal limits. As for, we had done a bone marrow to rule out neoplastic disease, which had just shown hypercellular marrow with iron deficient erythropoiesis with normal myeloid and erythroid maturation. ACE levels are only 33 33 milligrams per deciliter. We had proceeded with cross-sectional whole body imaging, which showed metabolically active subcentimetric axillary para-aortic inguinal nymphs, not amenable to biopsy, and hence no biopsy was done. So I want to talk about in this patient, we had in the setting of ruling out all our differentials, we had ruled out inflammatory, infective, and neoplastic causes. However, we clinically had a suspicion of neurosarcoidosis because as the patient had clinically presented with erythema, bilateral heel skin lesions, which on further examination was likened to be erythema nodosum. She also had bilateral ankle periarthritis. And so in this clinical setting, we had thought of neurosarcoidosis to be a likely differential, even in the absence of again granulomas and the presence of diffuse lymphadenopathy. So in this patient, we had the primary difficulty was to differentiate between a neurosarcoidosis and an idiopathic hypertrophic pachymeningitis. So we had a few articles, went through a few articles across, published across nations. In India, we have pachymeningitis is mostly known to be idiopathic. Tuberculosis is a second leading cause. IgG4 is IgG4 is the next most common cause, and neoplastic is more less than 4.4%. So we had also had many case reports of patients who have presented with pachymeningitis initially, and then further on biopsy were proven to have neurosarcoidosis. The most common presentation in patients like that was headache, visual dysfunction, seizures, and most patients got symptomatic improvement. In 88%, most patients were noted to have symptomatic improvements once they were started on steroids. So back to our patients, as I had mentioned, in the presence of ankle joint arthritis, history of heel skin lesions, which was thought to be erythema nodosum and lymphadenopathy, and given the history of prior steroid use and generalized lymphadenopathy, a diagnosis of neurosarcoidosis was considered more likely. And she was therefore immunomodulated with methylprednisolone for 3 days, followed by once weekly for 6 weeks. And she's been following up on OPD basis. So learning points are how to diagnostic evaluation of a patient with pachymeningeal disease, incidence and common causes of pachymeningeal disease, and common imaging features of pachymeningitis.
Thank you, Dr. Amrita. Any questions?
There's no past history of tuberculosis.
There is no past history of tuberculosis.
Any other comorbid?
No. She was 39.
How is she doing now after treatment? Have we followed up?
She's on follow-up on OPD basis with neurology, and she's been immunomodulated.
I think it's fair enough. I think most of us, after ruling out infection and neoplastic, we'll give steroids, but it's good to have a close follow-up because we are not have confirmed diagnosis yet. So with that caveat, I think thanks for the presentation. Next presenter, Dr. Ramya from Medicine 3 in crisis.